physician is not technically competent to do something, he shouldn't do it. I live in Fort Lauderdale. We have sunshine almost every single day, 365 days a year, and it's pretty much around 85 to 90 degrees 365 days a year. So clothing is optional in much of Fort Lauderdale and Miami. You go to the beaches, there are new beaches and stuff. People pretty much walk around without much clothing on because it's super hot and musty. So you can imagine that the temperature, I don't want to break it down to this level, but it's true, that the temperature in South Florida leads to people being very, very concerned about their image and their figure and such, because it's so hot you don't walk around covered in clothes from head to toe. So in South Florida, it's common to see lots and lots of skin, right? Not because we're a debased people, it's because it's hot outside. So why would you wear a lot of clothes? Shorts for sure. You know, and corporate, even the corporate structure has acknowledged this, because up north where women might be required to wear stockings, they don't have to wear it down south because it's so hot. So you can imagine, there's more skin. Well, when there's more skin, there's more vanity. People are concerned with showing their bodies, and they want their bodies to look exceptional when it's being displayed in public. Okay, makes sense. So obviously, plastic surgery and elective surgery is huge in South Florida. It's like LA and Florida, South Florida, it's where the plastic surgeons come to make their fortune. Okay, makes sense because of our geographic location and heat and blah, blah, blah. Great. To my knowledge, I don't know this for a fact because I'm not a lawyer, but I think it was something like you can, as long as you're an MD of any kind, like you were licensed to give like Botox injections or maybe like lip injections or something like that. And we had notorious cases in South Florida. I'm not going to name the companies, but we had notorious cases in South Florida where you would have an MD who was a general practitioner, who isn't a specialized, plastic surgeon, that were giving women Botox injections in their face and, you know, paralyzing half of people's faces or filling people's lips with collagen, and they weren't skilled and trained, blah, blah, blah. And, you know, the American Medical Association started to crack down on that. I'm not sure what the legality is. But the reason why I give the example is that, listen, it's not that you're perpetrating your credentials, you are an MD or a DO, right? You are a medical practitioner, it's legit, you've been certified, okay, cool. You do have the right to run experiments on patients, you can prescribe medication and such, cool. But you don't have this other type of training, right? You don't have this specialized type of training. Insofar as you don't have specialized training, and the procedure that the patient's asking for requires specialized training, well, obviously, above all, this maxim implies that if the physician is not technically competent to do something, he shouldn't, right? You need to think about the patient, right? You're not technically qualified to, you know, put collagen in someone's lips or to put Botox in someone's forehead. You shouldn't be doing that. Now, granted, if it's the case, and I'm not going to get into the legality because I really don't know it, but if it is the case that there isn't a restriction on just a general MD, and I don't say that pejoratively, but just a general MD from injecting Botox into someone's forehead. So it's not a restriction legally, and it's not a restriction in the community that the medical professional is represented by, let's say the American Medical Association. Well, it's going to be sort of difficult to hold them accountable in moral grounds, right? Because, you know, they know what they're capable of doing. They have the assumption that they're qualified. They practice the act only to find out that it's harmed the patient. It's the responsibility then of the governing organizations and the law and the federal government to crack down on that, right? You can't just be an MD and do specialized care unless you have specialized training. Why? Because you have a duty of non-maleficence, right? You have a duty not to harm your patient, but it's not just not harming your patient. As I said, you shouldn't be doing particular procedures unless you have competency. The fact that I'm a PhD, yes, I'm a philosopher, I'm a PhD, but of all the branches of philosophy, ethics is my weakest. I wouldn't look for a job in ethics because ethics is my weak. Medical ethics I'm strongest in. But this is really the only branch of ethics that I ever really discussed. I understand the other branches and stuff, I'm interested to an extent in other branches, but I don't have an AOS, area of specialization, in those branches, so I don't teach ethics. Right? Similarly, you might be an MD and you might be qualified, you know human anatomy and physiology and blah, 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 blah. You didn't go on to receive specialized training. Specialized practices should be reserved for specialized, competent physicians. It's sort of basic. Okay. So, the duty to prevent harm. Right? The duty to prevent. This is going to be a gradation. I found this diagram. So this diagram isn't my construction. I referenced the diagram at the bottom of the page, Susan M. Wolf. This comes out of the Hastings Center Report, Volume 24, and the title of Susan M. Wolf's article is, quote, Healthcare Reform and the Future of Physician Ethics. Right. So this diagram is not my own diagram. I've reconstructed the diagram based on the article I found in the Hastings Center's Report. And here's the idea of the diagram, right? We have, how much time do I have? Wow, it's running out of time. We have, actually, you know what? I'm not going to write this down because I have about 15-ish minutes, so I'll just read it. In the left column, we have potentially beneficial treatment. In the right column, we have the physician's obligation, the physician's duty. Remember, as I said, and I didn't use the word duty, this comes in her journal publication. It's important to reflect back on, I think, number one, autonomy, and autonomy, to be clear, because this might not have been clear. The relationship between rights and duties isn't specific to autonomy. Rights and duties is a discourse which encompasses many, many things, of which the discussion of autonomy is but one. There's a general discussion which is conducted independent to any discourse on autonomy between the relationship between rights and duties, right? Where an individual has a right to X, there is a corresponding duty to respect that right. This is exactly what's being said here in the first column, or the first row rather, potential beneficial treatment and the corresponding physician duty. So number one, likely to save patient from great harm. The treatment is likely to save the patient from great harm. Well, physician duty, strongest duty to provide treatment. Where there is a huge possibility, and it is exceedingly likely, that we're going to save the patient, we, the medical practitioner, we're going to save the patient from harm. So that harm is, if we don't intervene with treatment or therapy, then there's going to be a huge harm. This is going to be important in the next section. So if we don't intervene, there's going to be a great harm. Well, we have the strongest duty to provide treatment, right? Treatment as a means of preventing the suffering and exacerbating the pain of the patient. So that should be clear. Number two, where it is likely to save the patient from some harm, right? So step down, right? Which the assumption is that, no, there's going to be a little bit of pain, there's going to be a little bit of harm, but the treatment is likely to prevent the patient from experiencing some harm. There's a strong duty to provide treatment. It's not the strongest duty, where there's a great possibility that our treatment as medical provider will greatly prevent harm. There's a likelihood that some harm might come to the patient, and thus our duty is a little bit weaker. Number three, likely not to prevent harm, but to confer some benefit. So it's not going to prevent harm. The patient might experience some harm, right? Likely not to prevent harm, but there is some benefit. Well, there is a weak duty to provide treatment, right? You have to discuss it with the patient. Here are the options, right? I want you to know, I'll give you a perfect example for number three, chemo treatment. Likely not to prevent harm. The actual treatment is probably going to, in a sense, harm the patient. Some of the healthy cells will be destroyed. Hair loss is obvious. Nausea is obvious. And I'm not a medical practitioner, but there's got to be a litany of adverse side effects. However, the benefit is worth some of those acknowledged, upfront, transparent adverse side effects. This is